So let's kick on, because as Zafar said, time is too short for this entire presentation. So CDC and prevention says it's the leading cause for fatal injuries of Americans between year 1 and 44 years, and fourth leading overall cause of death. And accurate and early diagnosis is the key over here, particularly if you are dealing with BAT. It is crucial to guide management and improve things for the patients while there is a window of opportunity to manage these patients and have a better outcome. So, what's the general impression about trauma in Pakistan? And this is what AI Copilot has given me. It says that you can pick whatever you want to pick. There is no robust data to support what I'm going to say later on. But we do not have the precise data as relevant, and only relevant to the hepatic trauma itself. It's just a journal overall figure from 1990 to 94. Somebody has said that the percentage or the number of injuries per thousand is about around 46%, and so on and so forth. So, but we do not have precise data as regards the trauma to liver is concerned. And then you have some information, as this has come out from a paper again from Karachi, which is showing us a generic form of the way trauma presents over here in Karachi and in Pakistan, but not much to talk about. So the liver is the second most frequently injured abdominal organ and most common cause of death in severe abdominal trauma. And the rate is pretty high for mortality, is 5 to 15%. I think we are across the board unanimously agreeing on this figure of 5 to 15%. This most common cause, as for most of the trauma, is motor vehicle accidents. And right lobe obviously is more often injured, 3 times more compared to the left. So who manages this standardized care for liver trauma? It's the American Association of Surgery of Trauma and Organ Injury Scale, OIS. It's mostly used by people whosoever has a tertiary care trauma center practice in their setups. And this obviously plays the role in guiding the management for the surgeons primarily, or the crash streams. But the system is also relevant as far as credentialing the tertiary or secondary care practices is concerned. So it relies on imaging and who operates the system, then the actual pathology which is being taken care of. So if multiple low-grade imaging injuries are present in a single organ, one grade is advanced to grade number 3. So, you know, if you have more than one form of injury, you always add on. This is how it started. I thought this would have been matured somewhere around 50s, but it only started in 1971, as you can see over here, and that too by the vehicle safety centers. So they wanted to define what is more important for our vehicle manufacturer. So around 1994, the first AAST revision came up for spleen and liver, and the next revision was in 2018, and that's what I'm going to address when I go forward from here. And it's made a difference. And the difference is primarily that the entire scale-up of higher grade injury is better reflected on our clinical practices and the management plans. For imaging, MD-CT remains a mainstay, and it's very obvious. In most of these situations, getting a MD-CT and that too a multiphasic CT is a bit difficult, but when you are talking of liver injury, for whatever reason, you need to have multiphasic examination. And the ideal arterial time has to be adhered to, because if you do it early, it will not give you the information which you are looking for. And most of the time, the early arterial phase is for the detection of pseudoaneurysms, and it's better to delay by 30 seconds by looking at the injector, not at the patient or anything else. and then doing your arterial phase. And so stands true for the portal venous phase. So the later, that is the 82nd figure, is better because these patients are already decompensated and they are being challenged as far as their hemodynamic status is concerned. The interesting data which I stumbled onto was written up by Faisal Khosa, and he brought up this good article on the dual energy CT, helping adding on information to the MDCT itself through this multiphase examinations. But the most important thing over here is the delayed scan. यार ये नहीं चल रहा, पहले भी आपको बताया गया, ये फारिग है. So the delayed excretion phase, which is 9 minutes delayed, is the most important scan over here. It's very essential to do because it will give you a lot more information about the parenchymal disruption than the active bleeding. The alternative imaging, I'll come to it later on, but extended fast, obviously when you do not have a good patient, you have nothing else to rely on rather than EFAST. Contrast enhanced CUS, we hardly ever use it, and not many centers, tertiary care centers even now use it in their clinical practice. But we all have angio suites available for quick use in these patients wherever we cannot find anything else, and or on occasions later on we can rely on the MRI. But this is the basic algorithm which is or should be followed, and it relies on how stable the patient is when he arrives in the ER and whether he is fluid responsive or not. And I'll follow the rest of the things later on. So looking through again the data, the StatPearls, which has now been abolished, it's not being sponsored or firmed up, but the minor liver injuries make up most of the hepatic trauma, up to 80 to 90%, and that means grade 1 or 2. I'll show you and share with you the grades later on. But the mortality obviously increases with the increase in the severity of the trauma itself. It really varies from center to center, so if it comes out from BAL 22, you can see the grading system is much more robustly presented. And for grade 3, which is intermediate, the mortality rate is up to 15%, which goes all the way up to 95% for grade 5 injuries, even in the best of the centers. And this is what comes out of Indian Journal of Surgery. Their figures are the best, actually. I think they have the best tertiary care service available in India. So it's the best 69% figure I've picked up from any study. So what are the injury categories? As Zafar pointed out, majority of the trauma is either acceleration, deceleration, or compression. What I liked most was the reflection of the lateral right trauma to the right lobe of the liver. The way it splits it up, it basically cuts through the liver in a coronal plane. In contrast, the AP trauma cuts more like at the point of adhesions or block. So the Cantelli line is the one which tears up on the anteroposterior walls. And same stands true, whether you have a compression from deceleration, which means that you have a compartment in which everything gets impacted up because of the deceleration process, or whether you are thrown back by a bomb or an explosion. So let's move quickly to the AST OIS liver grading system, which had come up in 2018. It's not new anymore. A revision is due, but I'll share you the examples and try to make it more simple for understanding. So whenever you have a subcapsular hematoma, less than 10% of the surface is involved, wherever it is, this will be grade 1. You can sit on it. And same stands true for a subtle tear, which is a linear less than a centimeter, although this is more than a centimeter in fact. So the tears are picked up more, मेरे पास control नहीं है, sorry, we don't have the laptop, so the tears are picked up better on active scrolling issues rather than single images. But anyway, grade 2 is when the same thing, the hematoma is larger than 10% up to 50% in a manner like this, or the laceration is longer and deeper, up to 3 centimeters. And similarly, the intraparenchymal hemorrhage shows up, which is less than 10 centimeters in diameter. But this is a safe grade. So grade 1 and 2 has lowest mortality and morbidity associated with them. So the tears can go in a craniocaudal direction, but the depth is what makes the difference in assessing these tears. So grade 3 is when your parenchymal hematoma is more than 10 centimeters and the laceration is more than 3 centimeters, or you have a complex subcapsular hematoma with surface coverage of more than 50%, as in this case. So you can appreciate the tear going right across segment 7. Here, more or less, the entire vascular pedicle is shattered right across. But this is still grade 3 because it is all contained well by the capsule of the liver and it's not spilled over into the peritoneum. So if you have a pseudoaneurysm like this, which is picked up either on the early delayed phase, you can coil it up there and then, and that is a salvageable situation. So that's the pseudoaneurysm showing up, and that's where the spectral CT comes into action, telling you more about the presence of hematoma. Grade 4 is when it becomes up to 75% parenchymal disruption, and as you can see, the entire right lobe is more or less disrupted in this case, and same stands true for the disruption when it extends beyond the capsule into the peritoneum. Here you can appreciate the actual live bleeding into the peritoneal recess. So there are associated traumas. So chest tube is in there. You can see that pneumothorax is present, and this hematoma then travels all the way through along with the capsule, and you can see that it changes the density as it goes down. The entire contrast changes quite dramatically. Grade 5, as most of the trauma is very ominous, is more than 75% of the lobar parenchyma is disrupted, as in this case, or it goes through the actual vascular pedicles into the IVC, and this is an urgent status where you need to open up the patient in order to salvage if anything needs to be done for these patients, and they remain stable for the procedure. Even then, we were able to do imaging in these patients. Ultrasound still remains relevant to some extent, that you can pick up things happening in the liver, but you can't really characterize them and grade them. But once you have a multi-series CT, then you need to grade them appropriately, as I've just already highlighted. And the bottom line is to pick up if there is evidence of extravasation or a pseudoaneurysm. Based on that, the next...
Sir, 5 minutes are left.
Okay. What about bile duct injuries? They are also associated with a high level of morbidity, mortality, and obviously prolonged hospitalization, because they keep coming back and you don't know what exactly is happening in these patients till you actually pin down the reason for it. They most of the time end up having all these problems because we keep missing these subtle injuries to the biliary tract in the initial phases. And most of them are iatrogenic, and we all know what we have done when the surgeons the radiologist or the gastroenterologist make a mess. We know exactly what we are doing. It's the blunt trauma which makes a difference, and we really miss them a lot on the initial phases. So the entire spectrum of things is available with us to work with, whether in acute stage or in a later stage. The CT remains the mainstay, but it is very poor in performing or detecting. The accuracy is really very difficult when the ability to pick up the leaks and the site of leak is just next to impossible in majority of the cases, and we can't tell these things apart, the lymphocyte abscesses, myelomas from hemorrhages or subacute hemorrhages. It's mostly on follow-up we pick up whatever is done. So anyway, looking at this is a grade 2-3 injury. We still have a fluid, but we don't know whether this is hemorrhage or not. And in order to pick up any leakages, this is where the nuclear medicine people come in very handy, and we can pick up smaller things. But when an IRSP is done, you can see how big the tears are along the biliary tract in such a patient. But scintigraphy is what gives way for us in picking up lesions or leakages within these large category 4 traumas. You can have better view with SPECT imaging. MRCP is helpful. Again, it's very difficult to see MRCP actually localized. You can pick up bile leakages, you can make out where it could be leaking from, but you still cannot precisely give where exactly it is happening. But this thing has made a difference, the use of the liver-specific contrast with the delay sequence. It can help in nipping down the actual site of leakage. Like in this case, TTU, you can pick up something, tear or myeloma, whatever, you can't really tell, but on a delayed liver-specific contrast, you can see there is a leakage within this thing. It's a myeloma. Obviously, ERCP and PTC both complement the remaining imaging, but this is helpful in the sense that you can do a PTC and actually show the leakages better than anything else. Sorry about this mess up. So gallbladder laceration here in this case, you can see the person who's been knifed through. Difficult to tell whether this is hematoma or bile leak. Again, helpful by follow-up. So in conclusion, CT is the modality of choice for majority of the blunt trauma related liver injuries, and CT guided management enables trauma surgeons to confidently treat these patients. Majority of the blunt injuries successfully managed by non-surgical things, and that's the key here, because if you pick up patients which can be managed non-surgically, that's the best way forward. Majority of the comorbidities associated with these patients after surgery end up being high mortality figures. The future directions are very interesting. The three-dimensional printing of the entire liver, showing what's the volume, and the actual development through machine learning, the algorithm of classifying these traumas into the categories which are useful in managing these patients. Thank you very much for your patience.